You're listening to There's a Better Way, smart talk on healthcare and technology. If you're up for energizing and story-driven conversations with national healthcare leaders driving industry innovation across the country, then you are in the right place. I'm very pleased to welcome Lili Brillstein to our podcast today. Lili runs her own advisory services firm called Bcollaborative, which is short for Brillstein Collaborative Consulting. Her name is practically synonymous with value-based care. Lili helped lay the foundation for value-based care models in the U.S., starting with an Episodes of Care initiative at Horizon Blue Cross Blue Shield of New Jersey. And we'll dig into that later in the episode. As Lili says, healthcare isn't just what's defined by health plans as covered benefits. On that point, I couldn't agree more. Healthcare is about patients and those who care for them. So with that, let's get started. Welcome, Lili. I want to thank you for joining us on the podcast today.
Thank you so much for having me, Melanie.
This podcast is about finding a better way in healthcare, and certainly the transition to paying for value versus volume is a great example of a better way. But it's a complicated and slow shift to make at scale. You have been at the forefront of this work, so I'm really looking forward to diving into your work in value-based care. But first, take us back. Let's start where you started. Where did you go to school? How did you get started in healthcare?
So I grew up in New York and got an undergraduate degree in business administration, and I got my master's at Hunter College in New York. And I think I always knew when I was in business school that I really wanted to do work in healthcare, but I didn't really know what that was going to look like. I knew I didn't want to be a clinician. I knew I did not want to be a hospital administrator, although I was one for a little period of time. In the late 1980s, I was in a serious relationship with a guy who was HIV positive. And if you remember back in those days, it was a very scary time. There were no meds yet. The AZT hadn't even been approved. The spread of HIV was rampant. There was tremendous fear. And we sort of lived a very secret life. Nobody knew that Joe had HIV and was afraid to tell anybody. And so we really lived a very secret life. And because he also had hemophilia, it was sort of the first time I had seen any kinds of collaboration in healthcare. Nobody in real lives knew kind of what was happening. It was then that I began to really feel like I was understanding where I needed to be and that I really wanted to be involved in work that addressed healthcare at kind of a bigger level than just what was clinical or point-in-time care. And I began to see sort of the need for clinical integration with what we now call social determinants of health and behavioral health support, things like that. And at the time, I was working at a great job. I loved my job. I was working at the Brooklyn Museum and doing research. I decided that I was going to pursue my master's in public health. I went to work for what is now Northwell Health in New York. I worked for a period of time there as the administrator for HIV services in that newly sort of growing health system. And at the time, that was about the time I started my MPH. And I also, as part of my program, I did an internship, and I chose to do it at the New York City Commission on Human Rights in the HIV discrimination unit. You know, if you remember in those days, right, these are the days when hospital trays were left at patient doors. People were afraid to even go in and see patients. It was really a very scary time. So I guess I would say that's how I kind of got started. And I was really very committed to that work. And honestly, never in 100 million years did I ever imagine I would work for health plans, payers.
That's quite an amazing story. Thank you for sharing that. I mean, from your deeply personal experience with HIV and what you explained as really the experience of coordinated care related to that treatment to a focus on public health, that's quite a start to your healthcare journey. Thank you for sharing. And where did your focus on quality come in?
I knew the coordination wasn't good enough to sort of get us to a really good outcome. And there really weren't very many good outcomes in those days. So I think really, again, it started there. And I don't think I necessarily even considered I was focusing on quality. I was focusing on sort of how do we support the individuals in everything that they need to be able to get well. And I understood very early on that it wasn't just clinical support, that there was so much else. I like to say these days, healthcare isn't just what's defined by health plans as covered benefits.
Can you tell me then, take that experience and those experiences and talk about what set you on the path to driving this movement toward value-based care?
The reason I really love working in this space, and I work to kind of progress the move, particularly in specialty care across the country, to value, is because to me, if we really are talking about value-based care, we're talking about models of care delivery and payment that support patients and their ability and their providers' ability, whether they're clinical, social, behavioral health, whatever it is, to get to the very best outcomes, to provide all of the care that's needed. And when we talk about value-based care, it's all of the care that's rendered to one patient, but across the full continuum of care. And again, just drawing on the experience that I was talking about earlier, it was a natural fit for me. And when I left Northwell Health and I was recruited to the first health plan I worked for, which was HIP Health Plan of New York, which is now Emblem. In those days, there really weren't a lot of people with MPHs working at the health plans. Today, happily, that is different. And so, I worried about the community that I advocated for the most were the people who were lowest on the totem pole, right? The sickest, often didn't have great caregivers, and were spending all of their money. I got onto the health plan side and nothing really computed to me. I didn't understand business people negotiating numbers, units of service numbers without clinicians at the table, and having not necessarily any idea what the impact of those decisions mean. And clinicians who were doing their jobs without any information about what was really in the contract. And so I began early in my 20 years on the health plan side, sort of choreographing a dance between the payer and our provider partners and trying to first get everybody to kind of listen to each other, support each other, and do work that was really focused on the members or the patients. Then when I got recruited in January of 2013 to Horizon, the Blue Cross Blue Shield plan in New Jersey where we met, they recruited me to build their episodes of care program. And when they first talked with me about it, I didn't even know what that was. I honestly didn't know what that was. And as I listened, I thought, oh my God, this is exactly the kind of work I want to be doing. And it was a perfect, natural transition.
And when we met, you were at Horizon Blue Cross Blue Shield, and you were, as you say, director of episodes of care. Can you just tell our audience what an episode of care or bundled payment is?
The way that I think about it is really everything that is related to a particular individual's procedure, a healthcare event, or a health condition. So, for example, if I'm a patient and I'm going to have hip surgery, I'm not only concerned about when the surgeon cuts into me and does, his or her job. For me, I'm concerned about that prehab portion. I have to get labs, I have to have radiology, I have to have blood work, then I have to have surgery. Then after my surgery, I have to have care to make sure, I can walk, I am not in pain, and I'm doing my exercises, and all sorts of things have to be considered. Like, do I live in a 5th floor walk-up? Am I able to navigate? Can I go home? Can I be somewhere else? And then, of course, the downstream potential impact of that, hopefully there's no infection, I don't have to go into the hospital, etc. So all of those things, whereas in fee-for-service, we focus on The surgeon has his or her job and they get paid for that. And the phlebotomist has his or her job and gets paid for that, the physical therapist, etc. The episode care model is intended to create a care delivery model that is collaborative, that integrates all of the supports that are needed to get to consistently good outcomes.
Can you talk about how you define value-based care today?
Yeah, I think from my perspective, I think value-based care really is about sort of creating care and payment models that support comprehensive, collaborative care delivery. And I think that it gets bigger, right? It's not, again, just what health plans have defined as covered benefits. It has to, contemplate things like, transportation, right? In, food and things like, does the patient live in a fifth floor walk-up? Does the patient have a refrigerator if that's required to keep medications, cold? And so I think it requires so much partnership and so much collaboration because it's a complete rethink of the way we think about healthcare and pay for healthcare in the country.
Can you talk about some innovations right now that are working?
Really, right from the very beginning, when we were working on the Horizon program, and I got there, and they had just come out of. They also had very mature patient-centered medical home model across the state, and they had just come out of pilot with hip and knee replacements. And I think there have been maybe 1,000 patients over the 3 years. And they brought me in and basically said, we've seen enough success in this pilot, now scale this thing. My job really was to figure out, how do I build a portfolio that tests this model broadly across multiple specialties and then deep within certain specialties? And how do we get beyond just surgical procedures? And so taking from my amazing program at Hunter, right, which was really a community-based education program. And I was always very comfortable with that philosophy. You go to the community and you don't share with the community what you've built for them, which is typically how health plans have operated. But you go to them and you invite them in to build with you. And so, that was really the spirit of the build of the program, which I'm always so proud to say really became the preeminent program in the country. I didn't do anything in that program without first talking and working with the providers. And as we built, we would continuously go back. And I didn't put anybody at risk. I had my executive leadership saying, get them to risk, get them to risk, get them to risk, right? Payers' number one priority is predictability of cost. And I was saying them, let's just see how this goes. If I'm right, I'm thinking we're going to develop these relationships. We're going to build models that are successful for patients, for docs, for the plan, for everybody. And they'll learn. Docs had never yet seen that longitudinal data. They had never seen that before. So we need to give them an opportunity to look at that data, understand, they may be making referrals and having absolutely no idea whether they're really effective or not. And I said, and I think if they're in this sort of live learning laboratory, which is what I thought of it as, eventually they'll figure out how to create success here. It's in their interest, right? Their patients will be healthier. They'll earn more money this way as well. And what happened was, so the plan allowed me to do that. What happened was the providers, this was wild. The providers began to think of us as their trusted advisors. And that does not happen very often between health plans and their provider groups. And so it happened in orthopedics first, right? We did the hip and knee replacements, and then we built in knee arthroscopy and some others. And then the next episode was maternity. New Jersey had the highest rate of C-section in the country, right? Where the World Health Organization suggests C-section is indicated 15 to 20% of the time. New Jersey had 45 to 50%. Again, I went to the OB practices in New Jersey, and they were really very interested in partnering, in building these sorts of models. And as the sort of program continued to evolve, providers would come to me with ideas, right? And say, for example, in maternity is a great example because we started, this is like 2013, all very sort of new and nobody's really very sure what will work and what won't. And we started with low risk pregnancies only. And I would say about a year in, maybe not even, the docs came to me and said, we're kind of getting the hang of this model, how it works. We'd like to start to include high-risk pregnancies. And so we worked to capture that data and include that. And about 2 years later, they came back to me and they said, we know that the care we render to the mom during pregnancy has a direct impact on the baby. And so we'd like to include the NICU period in this episode also. Very innovative, not an easy one to do. But so my point is that the doctors really informed and helped build this model. And I would say in more recent years, now with Bcollaborative, at one point I did a 2-year initiative with a health plan, with a pharmaceutical manufacturer, with a data analytics company, and with a variety of specialists, GI, cardiology, dermatology, rheumatology. And, pharmaceutical manufacturers, in my view, know a whole lot about adherence and adherence to medication. Why don't people actually take their medication? Why don't they follow their therapeutic prescriptions? What are the barriers? And being able to address those things has a very big impact on patients' outcomes. And so that's how I brought them in the first place. Anyway, it was a fascinating thing. We came together to build a model around a chronic condition. In this case, it was psoriatic arthritis, and it was really more about how can we actually create the infrastructure and build a model that could support a chronic condition, right? Not a one and done, like a surgical procedure, but really care that for which patients might have someone other than a PCP as their principal point of contact.
The examples that you're sharing are just really apropos for a lot of the content and discussion that we have on this podcast, it all comes back to deep collaboration across the industry. We've talked about on this show collaboration for interoperability, and your interoperability, collaboration for solving some of the specialty medications problems that exist in getting patients on their medications in time. Collaboration around value-based care is incredibly important and deep, and the change management associated with it, I'm sure, as you describe it, is why this is just such complicated and slow work. But as we get it right, it's lasting. If we do it wrong, it won't be lasting, right?
That's exactly right. And to your point about, we have to sort of focus now, but for the long term, right? It's the same thing. And that it's a very hard, that's what this is all about. It's about being able to not only focus, right here and now on the ROI this minute, but how do we create models that actually support individuals for the long term, and individuals meaning patients, providers, and all the stakeholders for the long term. And as I work with groups, I have a lot of startups that I work with. And in this particular environment, I tell them, as we're focusing on chronic condition management, and again, hearkening back to my passion, right, around HIV, which unbelievably has become a chronic condition now, right? I'm very concerned about. I think those are the folks, people with chronic conditions who've been the most adversely impacted by fee-for-service, right? They need comprehensive care and they get individual units of care. So I think I tell lots of the groups that I work with today, as we focus on the chronic condition and the long-term goals, both in terms of critical outcomes and financial models, we need to also keep an eye very closely on what are the interim goals and successes we can create, because otherwise it becomes very difficult to get the ear of the payer or others to really be compelled to take action.
We've spent a lot of time here at SureScripts thinking about provider burnout, right? For doctors, for nurses, for pharmacists, especially during and post the pandemic. It's just been, has that made it even harder to focus on this work? Or does it somehow make it easier once you get past the initial change issue, that there may actually be some efficiencies in this work?
Yeah, it's the latter. That is what I see happening, right? Once, again, I think the beginning part, just getting groups together, different groups, meaning, docs, community support, behavioral health, payers, getting them together to listen respectfully and actually identify the expertise that others have and recognizing they can't do it on their own. That is the hardest part. That is really, and coming in, I used to say to my team before we would go into a meeting with providers, I would say, okay, remember, we leave on need to know everything and be right about everything here at the door. We're coming in here not to talk about anything we think that we're building. We're coming in to invite them in to share with us.
Can you share the role of data in this work?
From my view, I always start with the payer, who has the longitudinal view of the patient, right? Which again has not really ever been seen by the providers. They only see the data that relates to the care they specifically render. And so the data that shows the full spectrum of care across the continuum that individuals receive allows physicians to understand where there are variations in the care and the outcomes that really they may not even be aware of in their own practice, doctor to doctor, and within their own market. And so, again, in my view, the idea is to address the variability in care, cost of care, to get to most consistent outcomes. So certainly that's information that informs the care team about where they might make changes, in terms of who they refer to, where they do their procedures, et cetera. Then the clinical support, the data that the physicians have, critically important, right? But the payers don't understand, don't have data around a lot of the information that relates to the patient at a clinical level, and the physicians. By integrating that with the claims data, really you get a much fuller picture. The other thing about it is when identifying kind of quality metrics, right? I talk about we start from the end first. What are we trying to achieve here? What are we trying to get to? And, when I first got to Horizon, in that hip and knee program, there were more than 200 data elements we were capturing on every patient. So I think every single time that somebody touched them, we had to know, and it was incredibly onerous for the docs. But ultimately, as I scaled the program, we narrowed that down, and we had 2 or 3 metrics that were we measured across all episodes, and they were things that we could capture in the claims data, like ER visits, readmissions, and extended use of opioids in some of the episodes. And then we turned to the physicians and said, how do you know, how will we know we're successful, right? What metrics, from a clinical perspective need to be captured to know that we're successful? And the doctors have that information, right? In orthopedics, it was often pre and post functional assessment. In maternity, one of the big metrics was captured by claims, which was the rate of C-section, but we also had a few others. So the point is that the data, the integration of the data, the clinical data and the claims data, is really important to be able to provide comprehensive care and get to consistently good outcomes.
Now the EHR is largely fully adopted, and it ostensibly is comprehensive data on a patient, especially when interoperability is fully working, which I understand has got a long ways to go, but it's really, it's something we at SureScripts are very focused on, is bringing interoperability across the electronic health record. And now you're talking about putting the clinical data from the electronic health record together with the claims data from the payer. And you're really, I think, talking not only about a comprehensive single patient record, but analytics, right? That help a patient or help a provider understands what's happening with the population that they might have. Is that where then we get to population health?
Yeah, 100%. There are very few people who are going to be able to take a big mess of data and really understand it without having it, sort of synthesized to sort of tell the story. So yeah, I think, again, when I think of pop health, I don't think of it so much in specialty care. I think about it more in terms of primary care, although, I mean, it can be applicable in specialty, but it's more about preventive health and keeping patients healthy. But I think analytics are critical there, and they're critical in terms of specialty care, both in terms of outcomes and also process. And what I mean by that is, historically, the health plans are very involved in sort of, and even many that have their P4P programs are involved in supporting, paying for activities that the health plan tells the provider to do, right? Check the HbA1c, check the blood pressure, et cetera.
We've thrown around a lot of terms, and there are a lot of terms associated with this big value-based care world, from P4P or pay for performance, ACOs, accountable care organizations, PCMH, patient-centered medical home, episodes of care, bundled payment, population health. They're all parts of value-based care, right? Does any one stick out amongst all of them, or are they all things that need to work in concert with each other?
I think they're all elements of value-based care, right? And they all need to work in sync. And so, PCMH and ACO, the ACOs were intended to be integrated delivery systems, but really they're pretty much primary care, focused and attributed. So we have those models. Then we have episodes and bundles, which are the specialty care models. All fall under the umbrella of value-based care. But today they don't actually all work. They're not very well integrated, right? And so as I think about like CMMI's new ACO Reach initiative, for example, those are primary care focused ACOs. But one of the biggest goals is to figure out how do we integrate specialty care into those models for patients who are living with chronic conditions. And it's a topic of conversation across the country with payers as well. How do we sort of figure this out? So I think we need to continue to move forward and now begin to integrate these models that grew up kind of individually and figure out how do we really provide comprehensive care. And it all falls under, I think, that umbrella of value-based care.
So with all of this going on in the market, have we reached a tipping point on value-based care?
I think today the point we're at is we need to take those few specialty care models and really begin to figure out how do we integrate them with the primary care models. And that doesn't really mean, to my way of thinking, that the primary care docs are kind of, the bosses of the specialty care docs and direct them, but that they need to share governance, for example, in the ACOs and need to really be engaged in decision-making with the primaries. And the last thing I'll say about that too is that, specialty care isn't a thing, like primary care is a thing. Specialty care is a lot of things. It's orthopedics, it's, behavioral health care, it's infectious disease, it's a lot of those. So you can't just have one specialist on the governance committee, for example, and presume you have specialty coverage. So it's complicated.
Well, so beyond the transition to value-based care, what other areas of healthcare do you see having an impact or making us more patient-focused?
I've seen some very interesting, cool examples of partnerships between companies that might not have anything really to do with healthcare and are incorporated. So like Nike has done some, interesting work with groups. There was a model, I can't remember who it was now, but I've seen hospital groups and physician groups working with non-traditional partners to develop models and, again, leverage expertise outside of their own to build models and build experiences that focus on the patient that they might not have been able to do, on their own.
All right. What could we be doing better today?
I think what we could be doing better is being willing to listen to each other. People often tell me, they learned so much from me, and I think they always think they're learning from me, but I'm sort of secretly always listening and learning from everybody else. That's how I built the program at Horizon, So I think being willing to listen respectfully and come in with an open mind, don't come in with decisions already made that the only way this will work is if the payer gives us more money or any other sort of decisions. So I think, to me, that's the biggest hurdle, is getting past the sort of suspicions we've had. Providers have not had great experiences with payers and vice versa. And we have to be able to move beyond that, right? I would say that's my number one thing is, be willing to partner with people and stakeholders you might have been horrified to partner with in the past, and be willing to, understand that together you'll be able to build something much better than you could build on your own. And I've seen that, over and over and over again in my experience.
I ask all of our guests this question because to be in this market, to really be progressive in this market, you need to be inspired. Where do you go for inspiration?
Oh, where do I go for inspiration? I don't know. I think I'm inspired every day, because I spend my days really talking on Zoom and when I can in person to people all across the healthcare continuum. And every day, there's something that gets me really excited that I hear somebody talk about, and they may not even be thinking of it as something innovative, but I'm always thinking, oh, wait, maybe we can incorporate that perspective or that thought. I am an extrovert. I get a lot of my energy from my interactions with people. And so I guess I just am inspired by the folks I see and talk with every day. Even the ones who are terrified of coming into the models, who think, let me retire before this ever gets to me. Seeing them, being able to talk to them and work with them and see the evolution, the movement in the space is tremendously inspiring.
So last but not least, look ahead 10, 20 years and tell me what healthcare in America looks like, assuming everything you want to accomplish has come to pass.
I think what it would look like is very different than what we have today. I think it would have lots of, you talk about interoperability, and I think it would have a lot of data interoperability and lots of communication across the healthcare continuum with a focus on patient outcomes and reimbursement that supports those outcomes, not reimbursement that's paid based on what whomever the payer is wants to happen, right, in terms of the process. So yeah, I think it would be comprehensive collaborative models that are focused on getting to the best outcomes every single time with the most efficient use of resources.
Exactly. That's great. Right. Well, thank you so much for sharing your story with us today, Lili, and focusing us on collaboration and a willingness to partner, all in the name of serving patients and those who care for them.
Thank you so much, Melanie.
Thank you, Lili, for being on the show today. Earlier in our conversation, you shared that when you were studying business in college, these new value-based care models weren't even a blip on the radar. None of it was happening yet. We were paying for units of care, and we're still doing that today in many cases. But I am inspired by what you said, that it's important to come to the table with an open mind, that payers and providers can work together, that we can build something much better together than we can build on our own, and that in healthcare, we can have a system where we focus on patient outcomes, and that we can set up reimbursement to support those outcomes. Thanks to you, Lili, we're much closer to making value-based care a real part of American healthcare. Thank you for listening in today. If you've enjoyed this podcast, please rate, subscribe, and review. There's a better way. Smart talk on healthcare and technology. With your help, we'll continue to bring great conversations to the fore and to the wider listening public. Thank you.